Welcome to all the senior professors, distinguished gathering, and to all our viewers who are watching this on our YouTube channel. Thank you for being here today for a very important lecture by Professor Ranjit Manchanda. He is from UK. He is a professor and consultant of Gynae Oncology at the Wolfson Institute of Population Health at the Queen Mary University of London. And he works at the Barts Health NHS Trust at the Royal London Hospital in UK. So this year, he was awarded the Distinguished Chair of Oncology. The chair has been set up by the Infosys Foundation, and it aims to foster collaborative exchange for research and training, as well as it helps us to enrich various future development programs. So we feel extremely honored to have Professor Ranjit Manchanda here. He did his MBBS and MD at AIIMS before he moved to UK, and he has been one of those who has constantly been giving back to his country and to his alma mater through a series of training programs over the years, enriching our services by helping us set up a familial cancer clinic way back in 2010 when we hadn't yet started even thinking of these things. And it has reached a point where we can now talk about mainstreaming these kind of services for the general population. So we're very excited to have him and to hear more from him. Professor Manchanda.
Thank you very much, ma'am, for that generous introduction. It's a great honor and privilege to be here amongst you and to talk about something I feel really passionate about. That's a population-based approach to gene testing. So I started my journey at AIIMS many eons ago, and this is something I pursued following my PhD in the UK. So just some disclosures. I get research funding from various charities for population testing and other disclosures which are not related to population testing. I'm going to cover the background to this. Going to talk about the Jewish population model. Going to talk about the general non-Jewish population studies that have been, some of them that have been done and we're doing, and end with a trial we are planning to take forward. So breast cancer, ovarian cancer, endometrial cancer, and colorectal cancer account for 50% of women's cancers. There are about 5 million cases annually globally, about 250,000 suggested to be seen in India, and about 115,000 occur in the UK annually. Importantly, the burden of disease is stated to increase quite significantly over the next 20 years, and that will present a big challenge for all of us. And Globocan suggests that the number of cases and the number of deaths, you can see quite stark figures on the slides, will increase both globally and in India, therefore, because we are 1/6 of the global population here, and of course in the UK, where I'm based just now. So our research strategy is based on simple principles. Can we better identify people at increased risk or high risk of disease? Can we therefore better screen and prevent cancers in them? And through that approach, we could probably reduce cancer incidence and mortality. There are two approaches to this. One, of course, as Professor Bartla just said, we'll be implementing mainstreaming testing at cancer diagnosis, so moving a step beyond a family history-based approach to identifying people at risk, which can also facilitate novel treatments and clinical trials which may improve survival. But what I'm going to talk about today is something which probably and should have far more impact, and that's a population-based approach to gene testing. Both these approaches can increase ascertainment. 20% of ovarian cancers, 15 to 20% of ovarian cancers, about 4% of breast cancers, 3 to 4% of endometrial and bowel cancers are caused by high-risk, well-established high-risk genes which have clinical utility. So we have these breast cancer genes which are associated with increased risk of breast cancer. The most well-known suspects, of course, are BRCA1 and BRCA2. Again, in ovarian cancer, there's a panel of about 9 genes. Bowel cancer and endometrial cancer. In the UK, we estimate that probably about 700,000 people with cancer susceptibility gene carriers. If we assume the same prevalence, and we truly don't know in India what the prevalence is, then you could have about 17.5 million people here who are at high risk of cancer. So what is the advantage of finding out if someone is at increased risk of cancer and carries one of these gene mutations or pathogenic variants? There are opportunities depending on the cancer phenotype for surgical prevention. And for ovarian cancer, for example, there's the option of risk-reducing salpingo-oophorectomy on more novel approaches which are available in clinical trials today, like early salpingectomy and delayed oophorectomy. The opportunity of hysterectomy and BSO in Lynch women, or risk-reducing mastectomy for breast cancer prevention. There's the options of breast cancer prevention with tamoxifen and anastrozole, or endometrial bowel ovarian cancer prevention with aspirin. Option of intensive screening for breast and colorectal cancer, options of lifestyle reproductive choices which affect your risk, and pre-implantation genetic diagnosis. So these are all the benefits. Of course, they have to be weighed up against some consequences or risks or concerns that people may have. The issue of impact on family dynamics, emotional impact, anxiety, distress, insurance, marriageability, stigmatization, and affordability or cost effectiveness. The traditional model of gene testing currently involves testing people who have a strong family history of cancer. And the rule of thumb is that if using a family history, if you have a 10% chance of carrying a BRCA1 and BRCA2 gene mutation, the health system invariably says, okay, you're eligible and you can have gene testing. This probability used to be higher. It used to be 20% earlier, but over the years, as the cost of testing has fallen, this has also fallen. Now, we all know Angelina Jolie. She has a strong family history of breast and ovarian cancer. You can see her mother had breast and ovary, aunts got breast, grandmothers got ovaries. So that's a typical strong, high-risk breast and ovarian cancer family, and a celebrity with the best access to healthcare. She had gene testing, was found to carry a BRCA1 gene mutation, went on to have risk-reducing salpingo-oophorectomy and mastectomy. So ovary cancer risk, for example, with BRCA1 is 44%, and breast cancer risk is 71% till the age of 80 years. This approach, however, has a number of limitations. Only a small proportion of carriers have a significant family history, know about it, and act on it. I mean, the large number of you sitting in the audience, and I just wonder how many of you know your three-generation family history reliably amongst your parents, grandparents, aunts, uncles, nieces, cousins, and so on. So there is limited awareness both amongst the population and amongst clinicians about this issue. Data suggests that over 50% of carriers are missed using family history-based criteria for testing. So in the clinical setting, if someone comes to see you with cancer, they may or may not give you a strong family history of cancer, but about 50% of carriers you will miss if you just go by the current clinical criteria or the way health systems work. Additionally, another problem we have is underutilization of gene testing. There's good data now which clearly demonstrates that only a small proportion of those who are eligible for gene testing undergo gene testing. So the hoops you have to jump through to get gene testing, you also have to use these restricted criteria, and then just put all of that together, and still only a small proportion of people who are eligible for testing undergo testing. There is also the issue of exacerbation of inequalities. And there's data, for example, which is published recently by Mary Beth Terry and a group, which shows that in Black African women, for non-Hispanic Black women, they're twice less likely to have a strong family history of breast cancer than non-Hispanic white women. If you look at biobanking studies, and the large number of biobanking cohorts where they've done genomic analysis, and they look at family history, and they look at the people who've been diagnosed to have a cancer susceptibility gene, then up to 80% of people who carry one of these gene mutations do not give you a strong family history of cancer and would not be diagnosed clinically on a population basis. So these are limitations of our current clinical approach. We did a study in a 16 million London population. We went down into the London genetic testing laboratories and took all the BRCA data and matched it for population and postcode. And we estimated the carriers in the population and the numbers that had been identified over the years, and gene testing began in the NHS. So in the NHS, we have a really well-structured system of regional genetic services, free access to testing at the point of care to the national health system, using well-established guidelines. And we found that despite 30 years of gene testing, about 97% of the high-risk cancer susceptibility gene carriers or BRCA carriers had not been identified. And if you further model this, and this line is, the total carriers in the population, and as the population increases, the number of carriers will go up. There will always be a gap that you can't pick up, because this is the line for the family history positive carriers. And even if you doubled the rate of testing, you have to wait for another 200 years to pick up those who have a strong family history of cancer, given the current rates of testing. So clearly, the current system isn't working well enough. I put it to you that why do we need to wait for people to get cancer to identify people in whom we can prevent cancer? Lots of us doing gene testing in clinic, and 1 in 5 ovary cancers patients I see, we do gene testing, we pick up a mutation, they're eligible for PARP inhibitor therapy, and they can have cascade testing in the family, but that patient really shouldn't have had ovarian cancer or could have been prevented. So diagnosing a cancer susceptibility gene carrier after a cancer diagnosis is a failure of cancer prevention. One option to try and tackle this is population testing. That's doing testing unaffected and unselected people. It's really amenable to change because two things are happening. Technology has advanced. You can do high throughput gene sequencing. You have NGS machines, and cost of testing is falling. In addition, it offers the opportunity for more personalized risk estimation. Aside from identifying high-risk genes, you can also do more personalized absolute cancer risk estimation. And with that, you can use to stratify the population for risk. And this is happening now. That provides the opportunity for risk-adapted, targeted screening and prevention. For this to be undertaken, the few things we need to, fulfill. One, the risk estimation must give a validated risk estimate. So, it must say what it does on the tin. There should be clearly defined interventions of clinical benefit to reduce burden of disease. There should be well-defined thresholds of risk for undertaking those interventions. They won't be eligible for everybody. And well-defined risk thresholds below which you don't need to undertake those interventions. If we test populations, we also need to remember the Wilson-Jungner criteria, and these have been adapted and modified over the years to adjust for population testing for genetics disease. And 4 important principles have been described, and I quite like this because it talks about, it's the ACE wheel. It talks about the need to have a purpose in healthcare value, and we touched about that in the previous slide. Also, the importance of a gene-disease association with test performance characteristics and therefore your ability to predict risk, the reliability of the assay, and ethical, legal, and social implications which should not be forgotten. So with that in mind, let's move forward to the Jewish population model for BRCA testing. So why the Jewish model? Well, you have a population where you have more frequent BRCA mutations and quite distinct 3 founder mutations which constitute probably 95% of the BRCA mutations in that population. So 1 in 40 approximately Ashkenazi Jewish individuals carry one of the 3 BRCA founder mutations, compared to approximately 1 in 200 the general population, when in some cases 1 in 300. Importantly, these account for about 40% of ovarian cancer cases in the Jewish population and 10% of breast cancer cases in the Jewish population. In the non-Jewish Caucasian population, it's much less. It's 15 to 20% of 15% of ovarian cancers, and maybe 3 to 4% of breast cancers. My understanding from data that's emerging from India, and this initial data, is you find similar high prevalence possibly for BRCA mutations, both at breast cancer diagnosis and ovarian cancer diagnosis. And some of the data has come from AIIMS, and my colleague Dr. Parmanik has done some wonderful work, as have Dr. Gupta and Dr. Sareen from TMH in Mumbai. So there have been 5 BRCA Jewish population testing studies across the world. We ran one in the UK, and this was called GCAPS. It was initially part of my PhD work. And I ran a randomized controlled trial across the UK Jewish community. We did pre-test counseling and then offered BRCA testing. The others have been cohort studies. And the other didn't, just the Israeli study, the B4 study, and the Canadian study offered just pre-test education without counseling, while in Australia they did both. Leslie Andrews did both pre-test education and group counseling. And that's just a picture of our consortium meeting a couple of years ago at the Bassas Center, which I had the privilege of chairing, on the Jewish population, investigators getting together there. We published a large number of papers from this, and I'll just summarize in the next few slides the outcomes from that work. So one of the key things was stakeholder engagement and involvement, and engaging with the Jewish community. So 1 year just went into just setting it up in engagement exercise. We found that up to 60% of BRCA carriers are missed through clinical criteria-based testing. The prevalence was consistent with the international literature. Our prevalence was about 2.9%, consistent with the 2.5% in the literature, almost evenly split between BRCA1 and BRCA2. A population approach to testing was feasible, acceptable, and had high satisfaction. In a non-inferiority trial of standard counseling versus DVD-based counseling, we showed that counseling could be undertaken on a community basis, and a DVD-based or a facilitated approach was not inferior to standard 1:1 counseling in terms of knowledge, risk perception, satisfaction, and equivalent in terms of uptake, and was more time and cost efficient. When we looked at the long-term follow-up data, which is 3 years or so, we found, interestingly, a reduction in anxiety versus family history testing with population testing compared to family history testing. So there's more anxiety reduction in the population testing arm. There was no difference in depression, uncertainty, overall impact, or distress with giving the BRCA gene test result on a population basis. Again, there was a reduction in health anxiety in both arms of the study, which was equal, but there was no increase in health anxiety or distress seen. We found no difference in total quality of life between the 2 strategies of gene testing, whether physical or mental quality of life. There was an overall reduction, a small reduction in quality of life in both arms, but that's just consistent with normative data with people getting older. Overall, people naturally coming to the study had an initial 96% interest in finding out about BRCA testing and possibly taking it, but only 60% intention to undergo testing, and ultimately we had an 88% uptake rate. A reduction in uncertainty, reassurance were factors which drove it. People who were married and cohabiting were 4 times more likely to undergo it, and those who were concerned about the risks of it, the various risks we discussed, were less likely to take it up. So that was the distinguishing factor between those who took it up and those who didn't, which is what you want to see following counseling. Now the Jewish population is unique in many ways because it also has a number of denominations. There are people who could be unaffiliated, liberal, reform, orthodox, majority, or traditional in their outlook. And what we did not find is a difference in uptake depending on the Jewish cultural identity or religiosity, or any difference based on their denominal affiliation, whether they were more religious or not, for example. This is the paper we just published a couple of months ago. And what we were interested in looking at, what always I wondered was, people who test negative, do they suddenly go and start smoking more, drinking more, eating more unhealthily? Do they stop going for the regular screening that they should have gone for? And we didn't find that happened with a population-based approach to gene testing. So there was no difference in alcohol frequency, physical activity, diet, smoking behavior, or standard breast screening behavior. I'm going to talk a lot about, in the next few slides, cost effectiveness or health economics. And if we are going to make change or bring about a new policy or try some new health intervention strategy, we need to compare it to a traditional strategy and see if it's cost effective or affordable for the health system. And health economics provides an opportunity for us to be able to do so, where you compare the costs and consequences of the new strategy with the costs and consequences of the old strategy to arrive at a decision. And if you imagine a situation where 0 is death and 1 is perfect health, and you got this scale, then something called a utility score is your quality of life on the scale of 0 to 1. So if you have breast cancer stage 4, it'll be X. If you have stage 1, it'll be Y. If you fracture your leg, it'll be something else. If you've got some other disability, it'll be something else. But you can always get a metric and a measure on this scale of 0 to 1. And if you multiply that by survival, you get what's called a utility score. Sorry, you get what's called a QALY. So you multiply utility score by survival, it's called a QALY. And you see the term QALY, or quality adjusted life, here used in health economic terms or health economic analysis, and that's what it means. And we use what's called an incremental cost effectiveness ratio, which is your total costs of one strategy minus the other strategy divided by the total QALYs or health benefits of one strategy minus the other strategy. So it is just that straightforward, a numerator and denominator, but how you arrive at those numbers can be a really complicated process. And in this context, we're going to compare population testing and family history-based testing. This is a cost effectiveness plane where you have effectiveness going from minus to plus and cost from plus to minus. If you have a situation where something is more costly and less effective, clearly it doesn't make sense to adopt it. If you have a reverse situation where something is more effective but less costly, it certainly makes sense to try and to consider adopting it. And actually, population testing for BRCA genes in the Jewish population falls in this box, as I will show you. In between the two areas of uncertainty, we have decision rules. Standard criteria by NICE in the UK is a decision rule of less than 30,000 pounds per quality adjusted life year. A rule of the thumb for the US is $100,000 per quality adjusted life year. There are well described thresholds by WHO for various countries and health systems. Some countries have developed their own thresholds, and a large number of them may not have done so. Now, if we look at the Jewish population, that irrespective of how many grandparents may be of Jewish descent, because Jewish people may marry non-Jewish people, we find in most scenarios, most of these numbers are minus. So up to 2 to 4 grandparent situation, this is cost saving for the health system. If you have one Ashkenazi Jewish grandparent, then this approach is. This the whole analysis was reviewed and undertaken separately by the York Health Economic Consortium through the NHS Innovation Accelerator framework, which reconfirms cost saving of millions of pounds for our health system in the UK and reduction in cancer cases using this approach. So population BRCA testing, the Jewish population, is therefore feasible, acceptable, has high satisfaction, is cost effective, can be undertaken in a community setting using non-inferior, cost-efficient approaches, and does not harm psychological health or quality of life. There aren't many interventions in medicine that saves both lives and money, but this is one of them. Now, this is just a project we are undertaking at the moment in my team, just to look at the awareness and the what's out there from a point of view information support in the Jewish community across London. It's called the Jewish Hereditary Cancer Review Project. These are colleagues in my team, and Katrina Sarig is our project director for this. So I think it's time to change paradigm in the Jewish population. Israel actually did do that, and on the back of a big research study done by Efrat Levi-Lehad, my colleague in Israel, and also a lot of the data we generated contributed to this decision making, as did others. The Israeli health system now offers population BRCA testing to the Jewish community. There was a slight time lag, I think, with COVID, but I understand it's now going full steam ahead. In the UK, I'm absolutely delighted that this is a proposal that should go forward and is planned to go forward. And we should be having pilot sites for clinical implementation of this through the cancer program, NHS cancer program, early next year. And there is an expert advisory group and a group of people working to implement this strategy, which I'm involved in. So coming to testing beyond a high prevalence population like the Jewish population, there are other also founder populations across the world. It's not just the Jewish population. The Jewish population is probably the most well known and the one where the largest proportion of mutations are belonging to those three founder mutations. So our general populations surveys showed that almost 70 to 85% of women had an interest in knowing about their risk and undergoing risk stratification for ovarian cancer risk management, and there were some studies we published around this. One of the questions we asked ourselves, one of the boxes I mentioned earlier, what is the threshold at which you should do an intervention which is effective? And what had not been defined earlier in the literature is what should be the threshold for preventive surgery, for example, for ovarian cancer. This is something we defined a few years ago, and we demonstrated through decision analysis modeling that it would be highly cost effective to undertake surgical prevention at a 4 to 5% lifetime risk threshold for pre or postmenopausal women. This would save 7 to 10 years of a woman's life and also be cost effective for the health system. So how helpful may 5% be? There is some modeling data done by colleagues in Cambridge, Professor Antonis Antonio in Cambridge, which shows that at a 10% risk threshold, you get 35. So if you take all women with ovarian cancer, then 35% of those cases may occur in women who have at least a 10% risk of ovarian cancer. But 60%, up to 60% may happen in those who have a 5% risk of ovarian cancer. So that could potentially be your target for targeting preventive strategies. That's quite a sizable chunk of ovarian cancers. But we are not quite there as yet at using technology to identify all those 5% of women. But we are all along that journey. When we went to women in the general population, and this is over 1,000 women we surveyed, and we asked them an operation to prevent ovarian cancer at these different risk thresholds, and where risk may be calculated using different variables and not just gene mutations, we found that 83% of them wanted to know about their risk. And the surgical prevention rate they would opt for was similar, independent of whether they had a high-risk gene mutation or whether the risk was calculated using what's called a polygenic risk score or a SNP profile and other epidemiological factors. So one of the things we've been very keen to pursue, and which we've progressed over the last few years, is therefore broadening guidelines to offer more people surgical prevention. Ovarian cancer has horrible outcomes. Very few women survive this disease. Most of them are going to succumb to it. However, our opportunity to prevent women from getting ovarian cancer is far greater today than it ever was. And I feel we need to broaden access to this. This is something we've demonstrated now through a lot of research work. We've definitely changed practice in our clinic over the last few years. And women with, for example, BRIP1, PALB2, RAD51C, RAD51G gene mutations, in addition to the traditional Lynch syndrome and BRCA genes, are offered surgical prevention. We also undertake surgical prevention based on risk assessment using family history, if it's high enough. And we published a scientific impact paper for the Royal College last year on this issue, which elucidates the situations in which surgical prevention can be offered, the use of HRT, and so on and so forth. Talking about personalized ovarian cancer risk prediction, it's possible to predict a woman's risk of ovarian cancer using various risk factors such as parity, hormone intake, contraception, age, family history, your high-risk genes you spoke about, but also SNPs. Now, single nucleotide polymorphisms are common genetic variants. Each individual polymorphism may have a very small risk of associated with ovarian cancer. For those which are significant, ranging from 0.8 to 1.4 odds. However, you could put a bunch of them together because they're common. People may have more than one abnormal SNP. And using a multiplicative approach in a polygenic risk score, you can then, for a proportion of the population, reach a situation where that's got a high enough magnitude combined with other risk factors to give you an effect size of absolute risk, which will meet your threshold for intervention. So you could stratify the population into low, intermediate, and high-risk women. And risk models like this have been developed, and some have recently been validated. One of these validation studies we were involved in, it was in the PROMISE program, work again done by our Cambridge collaborators. And this is now called the CAN risk model. And using SNPs and your various genetic factors, you can predict personalized ovarian cancer risk. And it was validated in the UK CTOX cohort, where the paper published recently out earlier this year. And you can see the observed by expected ratio is not far off a straight line. So using this risk model, we did a pilot population testing study. And we went out and asked women if they wanted to know about their ovarian cancer risk. It was a small study as a proof of principle feasibility approach. Just about 125 women wanted, and they all agreed to undergo personalized ovarian cancer risk assessment using a customized decision aid and an optional telephone helpline for counseling. And we found it was feasible, acceptable. We published this a couple of years ago. Had high satisfaction, reduced his cancer worry, and didn't affect other psychological health or quality of life. Similarly, I think breast is good 5-10 years ahead of ovary. It's a much more well-researched and studied cancer. And for breast cancer, there are very well-defined thresholds for prevention, which are established. A nice familial breast cancer guideline clearly defines who's in a high risk threshold. So if you have more than a 30% lifetime risk of breast cancer, you can undergo risk reducing mastectomy. You're eligible for chemo prevention. There's a moderate risk group between 3 to 8%, which is eligible for modified, more intensive screening, or you can have high risk screening if you have more than 8% risk in the next 10 years for breast cancer. So these strategies are implemented through clinical practice. And are well defined in a NICE guideline. We have a NICE guideline for ovarian cancer like this under development at the moment, but it'll probably take a couple of years before it publishes. So there is modeling data to show potential cost effectiveness of this approach for risk adapted breast cancer risk estimation to modify screening approaches. And there have been a number of studies. This is the PROCAST study led by my colleague, Professor Gareth Evans in Manchester, who's done a phenomenal amount of work to clearly demonstrate the feasibility, acceptability, and appropriateness of this approach for modifying a breast cancer screening strategy using risk factors, including epidemiology, mammographic density, and a polygenic risk score. All this can be put in the Tyrer-Cuzick model or the AIIMS model, which gives you a risk for which can be adapted to the screening strategy. And we now have a randomized trial which is running, the MyPEBS study. And in one arm, you have standard breast screening ongoing, and in the other arm, patients are being recruited to a risk-adapted breast screening strategy. And this will be followed up for outcomes and will influence policy, I'm sure, going forward. So I mentioned there are a number of models in the literature which can predict risk. CanRisk is the most probably well-known and versatile. There's also the BRCA Pro, PANG Pro, Tyrer-Cuzick models, which can also predict breast and ovarian or other cancer risk. So is population testing for these cancer genes in the general population cost effective? And this is a paper we published a few years ago working with a number of collaborators where we showed panel germline testing for BRCA and other high-risk breast and ovarian cancer genes was potentially cost effective in US and UK population. And we got a lot of airtime for this. And we demonstrated the potential population impact of number of cancers you'll prevent over and above your family history strategy. And also it could prevent, for example, 71,000 cancers in the UK and almost 300,000 cancers in the USA if we just tested for these cancer genes. This is a probabilistic sensitivity analysis. You can do a various range of sensitivity analysis on these modeling outcomes. And in this, you model you simulate various variables at the extremes of their confidence intervals or their ranges. And we find that as you're willing to spend, the health system is willing to spend a bit more money within the cost effectiveness threshold, your population testing becomes more cost effective compared to your family history testing. And this is 93% or 84% of simulations are cost effective for population panel testing. So the results are fairly robust. We went on to do a global economic evaluation for population testing for BRCA genes across various health systems. And we selected some countries like UK, USA, Netherlands, China, Brazil, India. So some high income, upper middle income, low middle income countries. And we found that it was definitely cost effective at $200 a test for the UK, USA, Netherlands, China, and Brazil. But for a low middle income, I'll come to that in a minute. And so this is just a busy slide, but I just want to highlight these numbers suggest that it was cost effective. They're below the threshold. These are negative, so it's cost saving in a societal analysis. A societal analysis is one where you don't only take costs of the health system into account, but you also take account into costs of productivity loss. So the person who's diseased or who has cancer won't be earning, for example, so there'll be loss of income. So those things go into a societal analysis, and because you take additional cost to the person who's affected into account, those are more cost. That approach is more cost effective. WHO and various country health systems mandate that type of an analysis. In the UK, we do not consider a societal analysis. It's only the government only considers a payer perspective or a health system perspective analysis. So that just says again it was cost effective in the upper middle income and high income countries. We modeled the cost at which, the price point at which it would be sensitive for the Indian health system. And we found this using a 3 times GDP threshold as WHO advocates would be $170. And really where it become far more cost effective is when the price point hits $100. And I think we're headed in that direction. We can see the costs of testing for BRCA are falling. The potential impact can be 800,000 cancers prevented, breast and ovary in India, 1.2 million in China, and you can see the impact there on the slide for the other countries. So what we need to do is move away, change the paradigm from high-risk testing with restricted access to people who can afford it, for whom it's available, or those who are aware, to more general testing. And this is one of our volunteers from one of our population testing studies. Lisa, I have consent to show her picture. She was found to carry a BRCA1 gene mutation. She would not have been found by the health system. So she went on to have early salpingectomy and then delayed oophorectomy in a protected trial. She went was found to have an early breast cancer because she then was able to access high-risk breast cancer screening program, and that's been treated, and she's well. So the current gene testing pathway it involves huge amount of clinician time, chasing, consenting, checking, visits, hoops you have to jump through, your referral, your 1:1 counseling, your consent form filling, phlebotomy, go to the lab, get the test, return the result. And it's hugely intensive in interaction and multiple steps. And it's not really amenable to large scale population testing, this approach. We need to digitize this pathway. And a direct to patient approach is really going to be the way forward. And this is what we want to do and take forward, where we digitize your consent pathway, your give and take of information pathway. You can create web apps and tools for this purpose. You can take digital consent. You can do gene testing through a saliva test rather than a blood sample. The reports can go directly to the patient and also to the consulting clinician and the genetics team. And you can you can provide virtual access and help and support rather than patients have to come into a intensive genetic counseling session and clinic. The other bull in the China shop is the issue of variants of uncertain significance. So one of the things you will get on a gene result, what we are interested in is to see if people have a pathogenic or likely pathogenic variant. That means it's disease causing. But also what this throws up is a certain type of variant where you're uncertain of the implication of the result. Today, it's not disease causing, so there's no direct implication. But in a small proportion of these individuals, that categorization will change over time and it may become pathogenic in the future. So we need to be able to manage the uncertainty around those results, and we need to be able to follow them up. And that's not well established or described, or it hasn't, doing that in a robust manner hasn't really come into practice properly as yet. But it's something we do need to address if we want to do more large scale and population wide gene testing. The other things we need to look at is the socio-ethics, the long-term outcomes, and the rates of screening and preventive interventions. Are they the same as we see in our clinics, or are they going to be different? So to address all of this, we have we're just starting a UK-wide study. It's called the Protect-C study. We are building these web apps and decision aids when we are going to digitize this whole pathway, as I described. We're working closely with a number of colleagues, stakeholders, primary care networks, decision makers. We will afford and provide saliva-based testing, which will involve qualitative analysis. We have a separate stream and arm on VUS monitoring, health economic analysis, and we want to look at long-term outcomes. So there'll be 5-year and up to 8-year follow-up. This is just a snapshot of what's happening within. There'll be a well-defined pathway going downwards for managing these patients for screening and preventive interventions and long-term data collection. The VUS work stream, we are working very closely with our CanGene Canva group led by my colleague, Professor Turnbull, who leads the variant interpretation and classification work across various UK regional genetic services and hubs. And we want to build an interface and try and automate and digitize the process where the patient can follow the variant over time, and we want to look at that outcome. I understand that we now here in India, through an initiative, also have the BRCA Indica Consortium, where they're looking at variant interpretation for the Indian population, which also is an exciting step forward. The socio-ethical study we have would involve qualitative interviews for people in different categories, whether they were found to have a mutation or a VUS at different time points along the study. And we want to look at their experiences on a qualitative basis and the various social and ethical issues arising from this process. We will also do SNP and polygenic risk estimation. We want to do this and give personalized risk estimation and see how we can stratify the population for targeted screening and prevention. So this is a big project, of course, involves a large number of colleagues, just to acknowledge everybody in the team, funded by Yorkshire Cancer Research, but working closely with various stakeholders right across the country and various cancer charities and patient groups. So do we prevent more cancers through population testing? Yes, we do. We've demonstrated that. Do we identify more people at risk? We will. Are we causing harm? Our Jewish population data suggests not. Preliminary data for the general population doesn't say so, but we need more work there. Is the high satisfaction? Yes. Is it feasible and acceptable? Yes. Can we do it outside a hospital setting? We can do it. Is it cost effective? We believe it is. We should change the paradigm in the Jewish population. General population testing needs more implementation studies and research. Important principles to bear in mind are there should be established clinical utility for doing testing. There's no point doing large 100, 200 gene panels, which there's nothing you can do with the result. So the list and applicability of what you test for will evolve over time. Equity of access and care is critically important. So consider socioeconomic status, underprivileged, underserved populations, and so on. We need robust context-specific health system models. There will not be a one-size-fits-all. What's going to work in one health system or one context will need to be adapted. It's not going to, the same approach may not be applicable in another health system. And a public messaging needs to be consistent and accurate, and we need to increase public and health professional awareness. So I do believe we are moving towards an era of personalized risk prediction coupled with targeted screening and prevention. And the technological advances we've seen, along with high throughput testing and falling costs, is going to facilitate this going forward. But it does provide a huge opportunity for us to prevent a large more number of cancers, as we've shown you, than we currently do today. But technology affords us the opportunity to do so. So just to thank my research team who are involved in a lot of this work, and colleagues, the Protect C team across the country. These are a number of colleagues nationally, internationally, groups we work with for our cost effectiveness and other modeling analysis. In particular, my colleague in London School of Hygiene, Tropical Medicine, Rosella Good, the GCAPS team, and the PROMISE investigators, PROMISE led by Ian Jacobs. Thank you.
Thank you, Ranjit, and I'm sure everyone will agree that that was a fantastic talk. And I would like to invite Professor Rama Chaudhary, who is here. She is our Dean Research at AIIMS. And as I mentioned at the start of the program, it is the research section which has facilitated bringing Dr. Ranjit Manchanda here through our Infosys chair. So I would like to invite Dr. Rama to say a few words, and then if there's anyone in the audience who has any questions, I'm sure Dr. Manchanda will be happy to answer.
Yeah. Thank you, Dr. Nija. I'm sorry I was involved in some meeting and I got delayed there. But whatever, I mean, the portion I could hear, I think it is, having a real vision for the future of good health of women in India also. In fact, if we know, the United Nations has given Sustainable Development Goals, which are 17 goals world over. And the third goal is about good health and well-being. And I think if we really follow the screening method which Dr. Ranjit Manchanda has brought out here, and are able to help these people to really know whether they are high risk, whether they can really take some preventive measure, and they can really, come out of this problem and have much higher survival rate by taking preventive measure. This will be really, really useful. Only worry about this approach, which I discussed with Dr. Ranjit yesterday also, was that whether it is acceptable to females in India. Because most of the time they feel that they will be more tense if they come to know they are high risk, whether they will be able to accept it. So I think the last slide was talking about, education and awareness. So that is very important. Once you make them understand that if they do go for ovarian tumors or, any other tumor, then it is going to be much worse for them. It's not only like affecting their health, it is affecting their family, it is affecting the hospital burden, economy and everything. So I think in totality, if we can really create that awareness in the general public, especially in women, that there is a way by which you can get yourself screened, you can know whether you have any risk or not, and if you do have risk, you have a measure to take care of that. And anyway, we do surgeries for many other things, but if we really explain them well, I'm sure they will be able to accept it. So I think somewhere that awareness is very, very important. And what the data he has shown, I'm sure it is very promising, and it has definitely shown good results. And many countries have accepted, many women are getting benefit from that. And this will be really good roadmap for the women good health. This is my feeling. So thank you so much, Dr. Ranjit. It was a wonderful presentation, and I'm sure there must be many queries in audience minds, or any question or any comment, suggestion. You please go ahead.
Hi.
Do we have a mic for him?
That's a really interesting all the time. It is pleasure to listen you. So, but my practical experience is there. We are actually the area of the precision medicine, but still we are paid, despite of being the premier institute. So we are still lag behind. Even we are getting the test outside of things like this. So that is the present situation in this. And though it is very much important, you already mentioned about that, but ma'am was telling just screening is very important, but in a highly populated country like India, I believe that's a huge load of the patient. There the screening is slightly difficult unless the high risk patient we can look forward. And regarding the surgery, ma'am says personally I counsel at least 20 to 30 patients personally with the high risk group, which having the family history, but not a single surgery I could did this time, but for last 11 years. So that is a practical thing. And regarding the prophylactic mastectomy also, so I think hardly that is being done in Indian scenario, that Indian mentality, I think that it doesn't suit for that. And some controversies are there also regarding the prophylactic, suppose helping oophorectomy like this, that two controversies are there if you clarify in that also. So if you see, that is also, we all know that could prevent up to 94% cases of this, the cancer development, because the peritoneum is the part of this thing that can develop another 6%. But question is that so many people that believe that ovarian cancer particularly arises from the tube, not from the ovary itself. That is the most of the literature also that mentioned. So some people are doing salpingo-oophorectomy, some people are doing oophorectomy, some people are doing only the salpingectomy. So that is one is the important controversy is there. Another controversy regarding the age, because somewhere BRCA1 positive patient, they prefer this thing 35 to 40 years, and BRCA2 slightly elder, like 5 to 10 years, that is 40 to 45 years. So that is also one is the controversial gray area, like which age group is suitable, particularly ovary, very precious organ for the woman, particularly the cardiovascular and the bone health. So
And answer each one of them. Yes, I think the fact that salpingo-oophorectomy is extremely effective at preventing ovarian cancer incidence, ovarian cancer mortality, and all-cause mortality is well established by cohort studies. The effect size you quoted of 94% risk reduction is the general population figure. So people at general population level risk, if they have a salpingo-oophorectomy, then the risk reduction is about 94-96%. For women who have BRCA1 and BRCA2 gene mutations, you rightly point out that there is a small residual risk of primary peritoneal cancer. That primary peritoneal cancer risk is reported at 2 to 4% in the traditional literature. However, a recent paper from colleagues in Manchester, where you have thorough assessment and tubes and ovaries, I'll come to the tube and ovary question in a minute, using a CFIM protocol and centralized care, demonstrated that in their cohort, the residual risk of primary peritoneal cancer is far, far, far lower. They hardly saw it. It was just a few, just minimal, far lower than the 2% and 4% reported in the earlier literature. So you got a much higher level of risk reduction with risk reducing salpingo-oophorectomy. I think some of the older literature from these studies came, I'm not sure whether they all used CFIM protocols at that time. It's really important when the salpingo-oophorectomy is undertaken, and actually surgically it's a very straightforward procedure. What's far more important is the pathologist. And we have Dr. Mathur sitting there who will tell us that the pathological assessment is far more important to pick up an occult cancer. 1 in 20 of these, up to 1 in 20 of these women with an occult stick or invasive cancer which will need treating which is not identified on either blood biomarker analysis of CA125 or ultrasound scan. Without doubt, the most effective strategy is bilateral salpingo-oophorectomy. Taking the ovaries around alone is no value. As you pointed out, that today we believe a large proportion of these cancers come from the tubes. I've definitely, in some colleagues and some patients who come into my clinic, I've occasionally seen just the ovaries taken out, in which case I've gone back and taken the tubes out. But our surgical protocols are well established now. In our practice and that of colleagues in other centers in other parts of the world, we all agree, the international literature shows that it should be salpingo-oophorectomy. We have published on this, protocols are published. We've also tried to spread the message through our clinical trial work. There is an MRCOG college guideline out last year which clearly demonstrates its salpingo-oophorectomy. That's important. Early salpingectomy and delayed oophorectomy avoids the early consequences of early menopause, and may be an option for some women who want to get some risk reduction when they've completed the family but want to avoid premature menopause and would not have otherwise had salpingo-oophorectomy. But that should only be undertaken in research trials. So tubes should not be taken out alone outside a research trial context, because we do not have any long-term outcome data to demonstrate the harms from this, or what proportion of cancers you reduce, we don't know. The other question was around ages. Yes, we tend to do BRCA1 surgery from 35, offer it from 35 onwards. We tend to offer BRCA2 surgery probably from 40 onwards. Again, that's in the RCOG guidelines SIP published last year, and there are other guidelines also which suggest these sort of age thresholds. In my experience, decision making can be complex and dynamic, is individualized, personalized, and depends on the patient's individual circumstances, her reproductive history, her wishes, the social situation, parity, work, a whole host of factors goes into it. And we tend to manage them in a multidisciplinary team where we have people providing HRT plans and menopause specialists or fertility issues being addressed, and psychologists and counselors and clinical nurses involved in supporting these women to help them make a decision. Decision making changes with time. Patients who come in today in clinic may decide not to have anything done and may change their mind a few years later. But those are all issues. There are different rates of salpingo-oophorectomy and mastectomy can vary across populations. If in a certain cohort or in a certain population it's a lower rate, then again, I think those are all areas which are prime for research work to try and understand the issues and try and address them. Again, what's critically important is patient choice. They shouldn't, nobody's forcing anyone to have anything, either with respect to gene testing or prevention or screening, but it needs to be informed consent and awareness and patient choice. And I think we need working closely with patient groups and support groups and engaging them is part and parcel and a key thing to do in this whole process and journey. And we find that there are a large number of patient groups who are keen to work with clinicians, engage with them, and they want this information and support to help them make choices. I don't know if I missed anything.
Yeah, thank you, Dr. Ranjit, for that wonderful talk. It gave us a great insight about screening. So my take was that, see, in our kind of a setup, we are really lagging because we don't have any kind of high risk or population-based screening in general so whatever you talked about risk reducing salpingo-oophorectomies and etc., we hardly ever get to see those. Okay, so we are that way far behind, and that's we don't get those kind of surgeries. We do wherever we get a situation where we get tubes taken out for whatever reason, maybe it's just a hysterectomy along with salpingo-oophorectomy, we do follow the CFM protocol in our department. But I guess those kind of stick-like lesions or early changes or intratubal neoplasm, you'll see mostly in these BRCA positive. And so unless we have those kind of testings going on, I don't think we have any kind of data, which can really talk about that. So I hardly ever recall that we have had a surgery or risk reducing surgery or a double mastectomy. There have been occasional cases, but they're far few and scattered like that. So that's what we have to start from scratch. All begins with once you do testing, only then you will get these kind of surgeries happening
Yeah, I agree. I mean, we need to start somewhere.
Yeah.
I understand some initial nascent work has started, and I was at a meeting with some of your colleagues at the Cancer Institute this morning, and they were describing that they were doing some gene testing and some work has started. But what I would be keen to do is engage and partake and contribute to developing this area of clinical work and research work going forward with you and colleagues around. So I look forward to that process. Internationally, doing gene testing and mainstreaming and identifying people at risk, either for treatment or therapeutic reasons or for prevention and screening, is becoming more and more standardized. And I'm sure that that will come in at the All India Institute also in due course.
Yeah, I would just like to add to that, Dr. Mathur, regarding the risk-reducing surgeries, that the prophylactic salpingectomy for the low-risk women is now come into some guidelines, and we are trying to do it more and more along with the hysterectomies for benign disease even. And at NCI Jhajjar, we are now regularly having some patients being who are breast cancer survivors, basically, who are being taken up for the risk-reducing salpingo-oophorectomies. So I think we will see more of it as we get more and more sensitized to it, and we really value your contribution. Dr. Raju?
Just want to add one point here, what Dr. Neja brought out. And some of our own colleagues suffer, and they come to us in a very late stage when we are able to do it. I think somewhere, this particular approach is so helpful. And I know it may not be possible for mass screening, but we can start with a small step, at least for the healthcare workers only, if nothing much more than that, and have some system of planning screening for all the females, especially in the vulnerable age, and prevent those who suffer or may be suffering later on. I think some initial step can be taken in that direction, if not as a mass screening. So something which can be really very useful, and we are very sorry to see that our colleagues suffer and we are not able to help that very much. I think that kind of awareness will
I
be
think
useful.
Dr. Raju has some valuable contributions to report in that direction.
Thank you, ma'am. Yeah, very valid point, and exactly what I mean. I'm from Preventive Oncology at National Cancer Institute there, and with the Dr. Sushma ma'am, collaboration with my other oncological department specialties at NCI, we just finished a 2-week cancer awareness and education camp, as well as breast and cervical screening camp for the female employees at the AIIMS.
Very
And
good.
we got a very good response, although we had a limit of only screening for 25 to 30 people in a day with the capacity we had. But the response was very much awesome, and they were asking for when the next camp happens. And we were able to get some screen positives, even both with high family history, and even for the HPV testing also we found some, with the opportunity screening we found some incidents. And the response again we got from the fact when we asked for the feedback is very much, this is what they're saying, we don't get time and we neglect ourselves. And when we asked for to answer your other question, is there a fear of screening? So most of them, they said the education part was the very best thing, because now we don't fear of going there and getting the screening and all. So I think these are very much important for our employees in this one.
As far as breast is concerned, even an annual mammogram.
Yes,
the
that
eligible age group, that is something which is not done even amongst doctors.
Yes, very true.
So a beginning has been made, is what Raju is saying, that era is now past, and the preventive oncology is well set up at IRCH and NCI with regular clinics. So we are very happy to see this great step forward.
Thank you, ma'am. Thank you. And sir, thank you. Very nice lecture, and I really enjoyed every part of it. So I have a couple of questions. So basically, first, for Indian population, we don't have any risk assessment tools. So the CAN risk assessment and the CAN risk tool and all, how better can be applied for the Indian population to get that one? And for the risk stratification, because we cannot again advise this genetic testing for everyone. So first, I think we need to stratify with the risk assessment tool who are high risk and low risk, and then maybe we can go for the genetic testing. And the second question is like the polygenic risk score is now very much, I think for the personalized thing, the polygenic risk score is very much important. So with the lack of this population data from India, population genetic data from India, how do you think, I mean, in the pretty coming years, can you think a polygenic risk score can be developed for Indian population and can be applied for the weightage for the risk assessment and all? So these are
Okay, yeah, the answer to the question is yes. And we actually had a program, we had developed a program. Professor Bartla was involved in it, some colleagues in the audience were involved in it, Professor Deo was involved in it. In fact, Professor Deo, myself, Professor Menon, and and Dr. Nitya Vadva from THISTI were the 4 leads of that program. It was called Suraksha, and we had funding from Department of Biotechnology and Cancer Research UK to precisely do this, validating the cancer risk model or polygenic risk scores for an Indian population and adapting it to see what the changes you need to make it valid for the Indian population. We did the pilot work, we set up a group, we had 5 centers across the country, 40, 50 people, we used to meet regularly, and we did the year's initial work. So it's a fully developed program ready to kick off, and COVID came. And COVID came and DBT stood strong, but Cancer Research UK pulled the funding. But we are talking about this. We have every intention of doing it. We want to do breast and also validate breast and ovary, and we will take this work forward. So we do hope to build and validate risk models and can risk, I hope. And Antonis Antonio, who has developed as the senior author on the can risk papers, was involved in this.
And the polygenic risk scores, so do you think we'll have a population data before? Do we need a population genetic database to have that weightage of the?
I think we need to do the validation and see what adjustment you need to the models. We need Indian population case control data sets. So what we want to do is do those studies where we do have those data sets where we can adapt and validate these models. So we have something that's adapted for and will work in the Indian population in the Indian context. We know very well that these models developed and validated in Caucasian data sets, their accuracy and performance characteristics falls in other data sets in which they're not developed and validated, including Asian data sets. So that is work that is important, and I think all the people are aware of it and are engaged in trying to address it, including the investigators who develop those models.
Thanks.
Thank you.
Thank you very much. I think it's been a wonderful afternoon, and I would once again thank Dr. Manchanda for a great lecture. I thank the audience who have come over here, and I thank the viewers who are watching us. And with that, we will close this session. I would like to request all the faculty members who are here to just step up for a photograph, and please do have a cup of tea before you leave. Thank you.